Good afternoon. It's my pleasure to be here. This has been an excellent summit, and I'm really excited for our last session where we're going to talk with some experts who are joining us today about what's new in bladder cancer research, where is the state of the field, what's cutting edge, and what are our clinicians and researchers excited about. Part of what BCAN does, in addition to wonderful programming like this for patients and support services, is to put on a grants program for bladder cancer researchers and investigators so that we can be a small part, or hopefully a large part, of the momentum in continuing to foster new information, new treatments, cutting edge technologies, and that's what we're going to spend the next hour and a half or so talking about now. So if I can ask our experts, Drs. Armine Smith and Dr. Matt Zibelman, to join me on stage, please. Thank you both so much for joining us today. Dr. Smith, I'm going to give a quick introduction. You can find their full bios in your program book. But Dr. Armine Smith is the Director of Urologic Oncology at the Sibley Memorial Hospital. She's also an Assistant Clinical Professor at Johns Hopkins University School of Medicine and Director of the Women's Bladder Cancer Program at Sibley Memorial Hospital. And her current research focuses on identifying risk factors for bladder cancer development, oncologically safe organ preservation in both men and women with bladder and kidney cancer, and improving outcomes from bladder cancer treatment. So thank you very much for joining us.
Thank you.
And Dr. Matthew Zibelman is a medical oncologist from Fox Chase Cancer Center. He's an associate professor of hematology and oncology and a genitourinary medical oncologist at Fox Chase. He also serves as the research director of Fox Chase Cancer Center GU service line. He specializes in genitourinary malignancies with a particular clinical and research interest in immunotherapy and immunotherapy-related adverse events. So thank you very much as well. So we are going to have an interactive discussion. I'm going to pose questions to one or both of our experts here to respond to. We will leave roughly 30 to 45 minutes at the end for questions from all of you. We'll have mics passing, so please jot your questions down, save those for the end. This will be recorded, so you can come back and revisit this. And keep in mind that our experts will be answering these questions broadly and speaking about clinical trials broadly. We encourage any case-specific or questions that are very specific to your personal bladder cancer diagnosis to be discussed with your clinicians. So with that, I'd like to open with a general question that I'd pose to both of you. If you could try to answer in a 2 to 3 minute sort of speech about what's exciting you right now in bladder cancer development. What has the potential to or might already be impacting patient treatment outcomes and lives?
Sure. So I'm the medical oncologist, so I guess I should start with some drugs. I think there's a new drug that is available called enfortumab vedotin, which I think has really made a huge difference for patients. And we've been using it for several years and are starting to learn more about it, and maybe some other places where we can use it. And I think we're seeing some fabulous benefits and responses in patients, and I think that's clearly making a difference for our patients. And then I'll sort of hit one other topic that I think is evolving and exciting that we'll talk about, I think, more later, which is something called circulating tumor DNA, which is something that may allow us to better measure and monitor patients' cancers and help us make some decisions about treatment in a more specific way towards patients that I think will hopefully be a really big part of our care moving forward. I'll try. No promises. I promise we will get into both of those later, but I will do my best to talk slower. Feel free to slow me down if I'm going too fast. I get on a roll sometimes.
And from the urologist perspective, I think there's a lot going on in bladder cancer. I think this is truly exciting time, not to have bladder cancer, but at least to treat bladder cancer. Because I think even looking back maybe 10 years ago, there was not much that was going on in the field. And now it's just this explosion of all the intravesical treatments, of all the immunotherapy treatments. We're working on more markers. We have the circulating tumor DNA in the bloodstream. We, on our side, kind of looking at the tumor DNA in the urine, so liquid biomarkers. We have some predictive biomarkers that are being worked on. There's this whole field of microbiome and how it's related to bladder cancer. It's just a lot, and it's so exciting to be part of it. And one thing I wanted to do is give a shout out to BCAN, because I feel like you brought so much awareness to this disease, and I think that was kind of the reason all this explosion happened as well.
Thank you both. So we're going to spend a little bit of time, hopefully in the next hour, talking about advancements in all of the stages of bladder cancer, and hopefully touch on each. And I want to start off with a question for Dr. Smith. Even before a diagnosis, where are we right now, or what is the state of the science on a screening test for bladder cancer? And are there ways to detect bladder cancer other than with a cystoscopy?
Thinking about the screening tests, there's a lot that goes into kind of even thinking whom to screen, how to screen it, how much finances does the healthcare want to dedicate to these kinds of questions that we're asking. I think for the high-risk patients, we still rely on very simple instruments such as urinalysis. And if there is something more, like any symptoms and things of that nature, we can do more advanced testing. But screening as such for bladder cancer is not, does not really exist per se. Now, that being said, we'll talk a lot more about these, liquid biomarkers and things like that we will apply not as much as screening, but for kind of detection of bladder cancer.
Mm-hmm. Okay. And so moving into the non-muscle invasive disease space, we've talked a lot at this summit and heard from other presenters about BCG. We know that BCG is the earliest form of immunotherapy to treat bladder cancer and still the standard of care. But we also know that there are many patients who are unresponsive or can't continue BCG. We know the shortages for BCG treatment. So I was hoping you could walk us through a little bit some of the new clinical trials we're seeing of them that have emerged with either combinations of BCG or novel therapies for non-muscle invasive bladder cancer. And I believe we have a slide, if we could pull that up.
Yep. So the slide is, not very fresh. So I think some changes have been has happened since this slide been put together. But I wanted to bring an example and kind of show you what's been going on in the field. And it's becoming a very crowded space. One thing to think about: the process of a drug development takes about 10 to 15 years. So all of these things that you see that started in 2015, even before that, they had a lot more work put into it. And I think, changes are slow, and there's a lot of kind of effort gets put into putting a trial together. It either phases out to be a great trial or not so great. And the reason BCG unresponsive space had the most research, because that was the area of the need. So BCG has been the gold standard of treatment since 1976 for non-invasive bladder cancer. We did great for a while, and then we had some issues with factories closing and shortages, and then the BCG naive space became a lot more, much of an area of the need. But as you can see, for the BCG unresponsive NYBC, we had trials with the systemic immunotherapy. We had a lot of the immunomodulators, the BON3 trial, the nivolumab trials, the QUIL trials. I mean, these are all the treatments, and trelimab as well as one of the immunomodulators as well, PD-1 inhibitor. Now, a lot of these trials had focused on that field. Some of these treatments obviously, resulted in FDA approval. So Adstiladrin was approved. Anktiva, which is the QUIL trial, the brand name for the drug, was approved. Vicinium was kind of left off because it didn't have great, I think, response as balanced with the side effects, so that's been abandoned. And a lot more trials, and atezolizumab, unfortunately, was not a positive trial. It was considered a negative trial. But there are a lot more trials that are kind of in the space are going forward. Now, with the BCG being unavailable in a lot of the places, now we've become, really acutely in need for something to replace the BCG. So a lot of these trials have also shifted into the BCG naive space, and Adstiladrin and I believe Anktiva and UGN. A lot of these trials are in that BCG naive and intermediate risk space as well.
Can you talk to us a little bit more about Adstiladrin? What is it? How does it work? Who might be eligible for that particular treatment?
And yes, Adstiladrin was approved, I'm trying to think about maybe 3 years ago or so. And it's a adenovirus, which is a vector. So, and it's a gene is kind of placed into the adenovirus, and it transmits this immunogenic response into a person's body. And it's pretty much interferon, which is one of these kind of active components that induces a potent immune response in the bladder. The installation is actually a little bit different than a lot of the drugs that we give, because instead of giving it every week for 6 weeks, it's given once every 3 months. So it's a little bit easier in that sense. I think it took a long while for the places to figure out how to, for the pharmacies to figure out how to kind of get the Adstiladrin, how to dispense it, how to store it. And I think that was a little bit of an issue with the implementation of Adstiladrin. But I think it's widely available in pretty much all the major centers now.
And then one product, we call it a drug, that's a little bit different from any of these is the TAR-200 pretzel device. Can you share what is that, where is it in clinical trials or in progress?
Yeah, TAR is different, and it's very neat. It's actually a device. It looks like a pretzel, so we lovingly call it a pretzel. And it's on, I guess, like the 5th or 6th iteration now. So we've had the treatment with the TAR that was impregnated with gemcitabine. Those were the Sunrise trials. And then, as you can see on the very bottom, there is a TAR2 inhibitor, TAR2 combined with citralumab, which is the PD inhibitor that's currently in trial. Also, I think there is a Moonrise trial with the TAR that looks at the a different medication that's used in a pretzel. But the way it works, it's placed in the bladder. It has a very slow, sustained release of this drug in the bladder. And the biggest issue with the intravesical treatments have been because, people urinate the drug and maybe it doesn't have enough time to bind to the bladder cells. So if we have anything that's a slow release like the TAR2, or we'll talk about the UGN, it has more time to get in contact with the bladder tumors and or bladder surface and show its effect.
Thank you.
The TAR2, multiple trials have been already completed. This trial is still ongoing. It's not commercially available yet, just yet, but the results have been promising.
When might you anticipate that would be available?
It's kind of hard to say, but if we're looking at the example of Adstiladrin, I think it would be like a 1 or 2 year lag. Yeah, but FDA had approved, I believe, based on one of the trials, it's been already approved, and I think it's mostly manufacturing.
And Dr. Zibelman, for those who are at highest risk in the non-muscle invasive space or who are not responsive to BCG, what about the role of immunotherapy for these patients, and what have we seen with immunotherapy treatment?
Yeah, I think, as Dr. Smith said, there have been a lot of new agents that are new intravesical therapies, so therapies that we give inside the bladder to try to prevent recurrence or regrowth inside the bladder. But we've also studied these systemic immunotherapy drugs, so IV or intravenous drugs that we've been using for a decade or so in patients whose bladder cancer has spread outside the bladder, and giving mainly pembrolizumab or Keytruda, if you've seen the commercials, for patients with non-muscle invasive disease who are no longer or did not respond to BCG. And I think there are some patients who can have benefits and have disease control with immunotherapy agents like pembrolizumab. The longevity of that has not been as long as I think we would have liked for the majority of patients. And so it's for patients who do respond, it may not be last as long. And so that's why some of these newer intravesical therapies are being looked at and potentially using them in combination. For example, the pretzel device instilled inside the bladder and eluting a local therapy inside the bladder, and then using the IV immunotherapy drugs as a way to sort of use them combined, we hope will help prolong some of the benefits that patients have.
Yeah, one thing I wanted to kind of mention to the wide audience, it's nice we get all this data, and a lot of the data is new, so a lot of these trials are reporting on 3-month response rates, and the durability of the response we don't know yet. And one thing that also happens, a lot of times these trials are conducted in centers with a lot of people, experts, et cetera. So once they come out of this initial phase and they get much more wider use, these numbers may not look as good. Just, I think it's just, the reality of the situation for a lot of these trials.
And so we can see, looking at this slide, how crowded it is with these new trials and treatments, which is a good thing. I mean, if we bump this timeline back 10 more years, there would be a lot less on the slide. But it raises questions about risk stratification, when to intensify treatments, who's eligible for which type of treatment. And so how have all the advances in clinical trials highlighted that need for risk stratification, and how are you as treating clinicians addressing that with patients?
The risk stratification for non-muscle invasive bladder cancer, I think it was put forward maybe about 5 years ago with the AUA and the Society of Urological Oncology. And it was broken down into low risk, intermediate risk, and high risk. And I think there was a lot of reasons for that. Even, stepping away from these trials and going into the standard of care, we needed to have more standardized way of addressing these patients. So for the low risk disease, which is low grade cancer, small, single recurrence in the bladder or single occurrence in the bladder, the treatment is a lot of times just removing the tumor and giving some intravesical chemo once after the surgery. For intermediate risk cancer, it's a little bit more heterogeneous depending on which society's recommendation, but usually it's either low grade, large, or recurrent, or high grade but non-invasive and small. And the high risk group is the one that has CIS, carcinoma in situ. It has the tumors that are more invasive into the surface, but they're not kind of invasing into the muscle, recurrent, prostatic urethra, these rare subtype of bladder cancer, the variant histologies. And the reason it's important is because people can jump from one group to another, right? So if you have a low risk, you can become intermediate risk if you have a recurrence. And if you have intermediate, then next time the cancer recurs, it's a little bit deeper, you're high risk. And we need to know when to pull the trigger to intensify the therapy, because we don't want to miss the opportunity for cure, and we want to treat the cancer when it's time. And then a lot of the times, providers had used inappropriate treatments for lower risk groups. And again, with the BCG shortage, it's become paramount for people to use the treatments appropriately for each risk group. So the high risk group is kind of the one that is the most threatening, obviously, to life. And I think a lot of the treatments and a lot of these clinical trials are put forth for this group itself. But as you can see, even intermediate risk group has some trials that are available to them. Mm-hmm. And again, this slide is a little bit old. A lot of these, Adstiladrin, Anktiva, UGN, I mean, these are all trials that are ongoing for intermediate risk and MIBC now.
Before we leave the non-muscle invasive space and move into muscle invasive, I just pose the question, what do we still need to know about non-muscle invasive bladder cancer? What would you say is the biggest research gap still?
There are quite a few research, I think, ideas that need to be explored further. One is, so we have no shortage of drugs right now that are in development. We do need to know the biomarkers, right? So we want to know which patients will respond to which treatments, because we don't want to give people unnecessary treatments. Some people are better at mounting immune response, some people are not as good. And these are the things that are being developed. There is a marker out there that's AI developed with the use of AI. It's called Vesta. It looks at the BCG responsiveness or potential BCG responsiveness. This is kind of this is the newer field, so I think we need more development there. The liquid biomarkers or anything that will help the patients avoid cystoscopies, because cystoscopies are invasive procedures. Anybody who's had bladder cancer, they have a lot of these procedures, and sometimes they de-intensify it, sometimes they have a recurrence and it goes back to every 3 months. And if there's anything that can replace the cystoscopy, which at this point in time we don't have anything, I think that's going to be very welcome in the field. One of the things that comes pretty close right now is the urine DNA, and we have a testing by Convergent, which is URAM, that's kind of gaining a little bit of popularity, and I'm very excited about it. And there's some of the other companies are also developing, putting a lot of effort into the space as well. I mean, one other thing is, as I mentioned, the microbiome and how it affects the immunotherapy response in the patients. There have been some studies in other cancers, not in the bladder cancer per se, and we're looking at it at Hopkins and a couple of other institutions to see if there's a way to optimize the immunotherapy response based on the microbiome composition that we have.
Yeah, I'll just add, I mean, I agree that biomarkers are something, I think, for all parts, all phases of bladder cancer, but certainly in non-muscle invasive disease, that are very exciting. And although I certainly am a proponent of systemic therapies, I do think we have to be cautious about systemic therapies in patients with non-muscle invasive bladder cancers, particularly because these are cancers that can potentially be cured with surgeries. And I want to be careful about causing patients long-term harms and toxicities from side effects of immunotherapies. And we have seen that from some of these drugs. And so I think there's a balance. And although it's, of course, it's a major lifestyle change to have your bladder removed, we do have to balance that with the potential long-term complications that some of our therapies can cause. And so I think that's sort of the ongoing balance that we're trying to strike for all of these patients.
Thank you both. So I'd like to shift and now ask a few questions about what's happening in the muscle invasive space. We can pull this slide down for now. And we know that the standard of care has been chemotherapy plus bladder removal. Is that the only option today? Who is eligible for other options like bladder preservation, and what does that entail? And I'd open it to either of you.
Do you want to go first, or want me to go first?
Well, I think maybe
I'll go first.
Yeah.
So obviously this is somewhat individualized to different patients, so in different situations and with different patients, there may be more or less options. I would say in this country in general, yes, the standard of care is most commonly some sort of systemic treatment, what we would call neoadjuvant therapy. And this is giving medicines prior to a surgery to remove your cancer to try to eradicate the cancer. When we talk about muscle invasive bladder cancer, what we're really talking about is cancer in the bladder that's invaded from the lining into the outer muscular wall of the bladder. And that is the risk factor that the cancer can then spread through the bloodstream and through the lymphatic system outside the bladder to the rest of the body. And so one of the main purposes of giving a neoadjuvant treatment, medicines before surgery, is to eradicate that microscopic disease that may be there to hopefully prevent the cancer from recurring or spreading after surgery. And so the way I sort of think about it is in patients who are eligible and able to get some sort of neoadjuvant treatment, we use the neoadjuvant treatment to clear or eradicate the microscopic disease in the body. And then we need some sort of treatment to the bladder to kill or get rid of the cancer that's there. For many patients, surgery is the primary option for that. One alternative that we can sometimes offer is radiation, and usually radiation in combination with a type of chemotherapy. And there are different chemotherapies that we can use in this setting. But we tend to limit the radiation to patients who don't have certain high-risk features of their cancer that have been somewhat shown to respond better to radiation. And so smaller tumors that aren't blocking the outflow of the ureters, tumors that are in one location and not in multiple locations. Some of those tumors can be amenable to using external radiation to sort of sterilize or treat all the cancer in the bladder, and then we give a chemotherapy or some sort of agent that helps allow the radiation to work more effective, basically makes the cancer more sensitive to the effects of radiation. So some patients can have that as an option and potentially avoid surgery in that setting. But for the majority of patients, surgery is going to be the best option to try to cure the bladder cancer, and is what we sort of see most often in this country. And then there is a push to try to better predict who maybe will respond so well to our systemic therapies that maybe all of the cancer would be eradicated and they don't need to go on to any sort of local treatment, whether that's removal of the bladder surgically or radiation. But that is something that we're still trying to figure out how we can predict better. So we can potentially provide that option for patients. Because what we don't want to do is offer patients to avoid surgery and radiation, and then they go on to have their cancer spread when there was maybe an opportunity to have cured it. And so really trying to identify those patients as well as we can, I think, is really essential to make that more part of the standard of care.
And so that was going to be my next question for you, is how do you identify patients that would benefit from adjuvant therapy? You're the expert. That's what
we're hoping to work with BCAN to figure that out. We don't have a great way of doing that yet. Hopkins and Fox Chase have actually collaborated on a series of clinical trials starting to look at that. We have these series of trials we call the RETAIN trials, looking to find ways to retain your bladder in patients with muscle-invasive bladder cancer. This group of trials has looked at a particular molecular marker, so mutations in the individual cancer, in a person's individual cancer that has, in other studies, shown a more likelihood of responding to chemotherapy, specifically cisplatin, which is a chemotherapy drug that we use for most of these patients. And so if you have one of these 3 mutations, you seem to have a better chance of having a complete response to the chemotherapy, meaning the cancer would totally disappear. And we know that because in some of the older trials, patients would go on to surgery and their bladder would come out, and about 35 to 40% of the times, there was no cancer remaining. And most of those patients go on to not have a recurrence. And so there's been this big push to say, if we knew who those patients were, could we safely allow them to not go right to surgery and have their bladders removed? And so we've been running these trials, and sort of where we are right now is there are some patients that do seem to benefit from that. In our first iteration of this trial, about a little less than half of the patients who had a mutation chose not to have their bladder removed, and about a little less than half still remain free of cancer and with their bladder intact. But about the other half of patients have had some sort of recurrence, either inside the bladder that was able to be treated or where the cancer spread. And so it's certainly not perfect yet. There's another well-publicized trial which allowed patients who had chemotherapy and then had imaging that didn't show cancer, had the urologist look inside their bladder and didn't see evidence of cancer, and those patients had the option to consider not going to surgery. And so far, with limited follow-up, that looks promising, and some of those patients seem to have done well. But it's really important to follow these patients longer term, because even if they remain disease-free without recurrence for a year or 18 months, we know that patients can have recurrences longer than that. And so it's important to sort of follow studies like that longer to really get a sense of that. And so we're hoping that biomarkers may help add to this a little bit more, whether that's using urine to look for microscopic evidence of the disease, or circulating tumor DNA, so looking at blood and looking for markers of cancer cells floating through the bloodstream, and that those may help us better identify these patients. So we're not there yet, but there is a lot of work trying to really identify these patients properly.
And how does a patient go about getting circulating tumor DNA or ctDNA testing to understand if they can help personalize their treatment more?
So right now, most of this circulating tumor DNA testing is still, I would classify as experimental. There is a company with an approved assay. It's been best studied in patients who have had surgery to remove their bladder, and looking at that time point whether they have circulating tumor DNA or not. Patients that do, their likelihood of the cancer eventually growing and showing up seems to be pretty high. Patients that don't may already be cured, but we don't really know over time how that looks for patients. And some of those may have no detectable circulating tumor DNA right after surgery, but 3 months or 6 months later may go on to have that. And so we don't yet know sort of the natural history for some of those patients. So we are looking at studies that are trying to help determine that prospectively. So where patients have their bladders removed and we make decisions about whether to give treatment afterwards based on whether they have detectable markers in the blood or not with circulating tumor DNA, and hopefully allowing that to be a better tool to help stratify and choose patients who need more treatment and who don't.
And you talked about adjuvant therapy and neoadjuvant therapy, and there are clinical trials that are looking at what's the benefit of doing adjuvant therapy or a clinical trial before or after surgery. And I would ask you both, should a patient consider doing a clinical trial as a treatment option, either before surgery or after surgery?
Yes, yes, and yes.
Expand on that a little bit. What would you?
So I mean, absolutely. I think clinical trials is how we've gotten to where we are now, and it's how we're going to make these next steps to really be able to identify patients who either can get certain therapies that are going to hopefully lead to better long-term outcomes or avoid surgery. So I certainly encourage that, and so certainly at centers as ours, those are going to be options, but certainly at lots of places around the country. And so I think whether that's looking at therapies to look at new agents that may be better than what we have out there, whether it's clinical trials looking at biomarkers to help better choose or predict who's likely to benefit, whether it's using these biomarkers to escalate care, patients who have markers that suggest the highest risk and we need to add or combine therapies, versus patients who maybe have a much lower risk of cancer growing or coming back, and maybe we can de-escalate or offer less treatment, less surgery, less medicines. And so I think sort of at all parts of the spectrum, clinical trials are going to be really important. I could talk about adjuvant, but I don't know if you want to touch on that.
No, but I think, sometimes patients have reservations. I mean, yes, if you're at the last resort, there's a lot more kind of ease in going to a clinical trial. But when there are options, people get a little bit confused. Should they go and should they not go? Clinical trials is, you're right, that's where we get our information, and the best, drugs come out of those too. And, when we design clinical trials, like nobody wants to miss the window of opportunity for the treatment for the patient. It's a lot of thought that gets put in when trials are designed to be able to let patients cross over from the treatment that doesn't work to the treatment that we know works, or go off the study. So a lot of safeguards are put in place for these kinds of trials. So I think, we do encourage you to go into trials because it's good for you potentially, and it's good for the science and the society in general. And I feel like there is, again, a lot of thought put into these trials to make them safe for the patients.
Yeah, I mean, that's right. It helps the field as a whole, certainly, but it hopefully also many times can help individual patients. And really we want to try to design these trials that can allow patients access to new drugs, to new ways of treating this that will help inform the field moving forward, but will help individual patients. And I'm sure we both have lots of patients in our practices who have benefited from clinical trials.
And so as we get better with these new drugs and systemic therapies and have more clinical trials, is there the potential for a patient with muscle-invasive bladder cancer to be cured from systemic therapy, medication, or radiation without surgery?
I mean, so we absolutely cure some patients with muscle-invasive bladder cancer now with the standard of care as it is. What we're not so great at is knowing exactly who those patients are going to be from the beginning, who's going to be cured and who's not. And so that is something that we're trying to get better at. And with these trials and maybe more tailored therapies, the fraction of patients that are cured will increase. But that's definitely the goal. That's probably goal number one, is how do we cure more patients of their bladder cancers?
Yeah, a lot of these, the data that comes from trimodality bladder preservation and some of the trials that you spoke about with the chemotherapy and keeping the bladder in place shows about 50 to 80% chance of cure with just either chemotherapy or chemotherapy with radiation. The question is, who are the best patients for it? So we just need to be able to select the patients the best. And what we've had trouble with in the past is even with going back and imaging the patients and re-resecting the area of interest, sometimes we miss the tumors that are hiding somewhere. So if we have better diagnostic imaging, if we have more kind of a genetic, like a tumor DNA, plasma tumor DNA, urine tumor DNA, those would be a lot more helpful. And then eventually, if we come up with the biomarkers of response to chemo or the genetic composition of the patient or the tumor, we can select patients better and help them keep their bladders.
Yeah, and to Dr. Smith's point, we were part of our urology group at Fox Chase ran a trial that I was a part of, where we simply just took patients who were going for surgery to have their bladders removed, and the urologist at the time of surgery in the operating room looked inside the bladder and did a very sort of mapped out, planned cystoscopy to try to predict who were patients that were going to have residual cancer in their bladder when it was removed and who wasn't. And they were pretty confident that in a high volume center that does a lot of these surgeries that they were going to be really, really good and show that if we do the way we do this, we'll do it well, we'll predict almost all of the cancers. And they weren't. And about 25% of patients who had muscle invasive bladder cancer, they could not see at the time in the operating room inside the bladder. And so just underscoring the fact that we are not yet good enough at predicting who's going to still have cancer left. And we have to be careful about these bladder sparing approaches, but hopefully some of these biomarkers will help us better stratify these patients and know who needs surgery versus who can potentially delay or avoid it.
Thank you. And so looking at our time, I want to make sure we talk also about what's the state of the field currently in locally advanced or metastatic bladder cancer. And Dr. Zibelman, what's the standard of care currently? Is it still chemotherapy?
So I guess it depends on what you classify as chemotherapy. So I think one of the, I'm going to segue into what your next question I think is going to be anyway. So I think I mentioned at the beginning this new agent, enfortumab vedotin. We affectionately refer to it as EV, which is a lot easier to talk about, or Padcev is the other name for it. And this agent, in combination with pembrolizumab, an immunotherapy drug, has demonstrated response much better than the standard chemotherapies that we have used for bladder cancer, for first treatment for metastatic bladder cancer previously. Up until the time of this combination, we were using some sort of combination chemotherapy for most patients, usually with either cisplatin or carboplatin. These are sort of cousin chemotherapy drugs that we choose based on how healthy patients are, how fit they are, how good their kidney function is. And we'd use them in combination with one or a few other chemotherapy drugs. But this combination of enfortumab vedotin and pembrolizumab was shown to really double the time before your cancer progressed and that patients on average survived compared to using that chemotherapy. So for most patients, that has really become the new standard of care. If we want, I think I made a little cartoon
if we can
about
pull
this
up
drug, which I can
the slides.
describe to you. All right, so this is my PowerPoint art. So I apologize if it's not totally clear, but I'm trying to help explain how this drug works. So this drug is what's called an antibody drug conjugate. And so you see the big blue Y there, that's the antibody part. So this basically targets a receptor that most bladder cancers express, something called Nectin-4. This basically just sits on the outside or the membrane of the cancer cell floating out there. And the antibody part of this drug floats around the body, finds that area, and sticks to it. And then there's this linker connecting this red blast here, which is really the idea is this is a payload. This is something that we're trying to bring to the cancer to try to kill or eradicate the cancer. And this can be a lot of different things. I describe it to my patients as sort of the Trojan horse model. You sort of bring this to the doorstep of the cancer and then sort of release this thing where the cancer is and hope that it destroys the cancer. In the case of this drug, this enfortumab vedotin, it's basically a toxin, a chemotherapy-like drug that we're essentially bringing to and distributing right where the cancer cells are. So I think I have a little, let's see how good my animation is.
Green arrow.
All right, so here's your cancer. And it has this marker, and so you give the drug, it's intravenous, it goes in and finds the cancer and sticks to it. Once it makes sort of it binds, it releases this toxin, which you hopefully go and destroys the cancer. So that's really the idea of how this is meant to work. Thank you. I'll be doing a PowerPoint tutorial after this if anyone wants to join. Yes, exactly. And so it's really, a somewhat more tailored, unique, innovative way of giving chemotherapy. It's still chemotherapy, though. This toxin that we're releasing is essentially a chemotherapeutic. It still has some of the side effects of chemotherapy. These can include rash, and one of the reasons for that is this Nectin-4 that the drug is targeting actually does live normally on some of our skin cells. So the drug actually attaches to some of our skin cells and releases this toxin in our skin, which can cause different sorts of rashes. It also can cause neuropathy, which is a numbness and tingling that patients can develop in their fingers and toes and hands and feet that can occur with more administration of this, just similar to what we see with other chemotherapy drugs. And so although I think this drug is certainly an improvement than the sort of more just carpet bombing approach we've done with chemotherapies in the past, it is still chemotherapy and clearly has risks and side effects.
And speaking of side effects and risks, this is a relatively new finding, so we're still learning about what those side effects may look like. Would a patient ever switch from one treatment to another because of side effects or because of another reason, and when and why would that happen?
Yeah, absolutely. I think particularly when we're talking about patients who have developed advanced or metastatic bladder cancer, so cancer that has spread from the bladder to other places in the body. Unfortunately, generally, most of those patients cannot be cured with the medicines that we give. And so really the goal is to help prevent side effects and complications of the cancer, to help them live as long as possible, maybe more importantly, as well as possible. And so if the drugs that I'm giving are causing more side effects than the cancer is causing, I don't want to continue to give those agents. And so we try to adjust the doses of the medicines, the schedule of the medicines, try to find ways to allow patients to stay on the drug if it's working, but certainly if it's not working or the side effects are more harmful than the cancer, then we would stop and switch to something else.
And can you talk a little bit about the role of precision medicine in this space and genetic testing, and are all patients eligible to have their tumors tested, and what might that help tell them?
Absolutely. And so using next generation sequencing, ways to look at the individual profile or mutation profile of cancers is really part of all cancer care at this point, and really any patient, bladder cancer or with other cancers, whose cancer has metastasized or spread are really eligible to have testing of their cancer to see what are the specific mutations that, one, maybe led to this cancer growing, but two, may identify vulnerabilities where specific drugs can target and kill it. And so we do that for patients with bladder cancers that have spread. There's a marker called FGFR, which is expressed on about 10 to 15% of metastatic bladder cancer patients, and we have a drug that specifically targets that mutation. So patients whose cancers have that marker are eligible for this oral agent that can help manage and treat the disease. There's also now a marker called HER2, which some of you may have heard of, associated with breast cancers, but is something we look at in a variety of different cancers. And there's a drug that targets cancers that have highly expressed this marker that's now approved across cancer. It doesn't matter where your cancer started from. If you express this marker in your cancer highly enough, you're eligible for this drug. And so this is another mutation that we are looking for and testing for, which opens up opportunities for patients. And we're hoping to find more of those. Sometimes bladder cancer and the world of lung cancer are somewhat similar, but the lung cancer doctors are a little bit, maybe more than a little bit, way ahead of us in sort of divvying up their cancers into subsets that have specific mutations that can be targeted with certain drugs. And we have a ways to go to identify those and catch up to them from that standpoint.
Mm-hmm. Thank you. And now, thinking broadly about all phases of bladder cancer, question I would pose to both of you is talking about when is the appropriate time to escalate therapy versus de-escalate therapy, and the need for clinical trials looking at both approaches. So are there clinical trials addressing both of those, and how do you determine when to escalate or de-escalate?
Yeah, I think the big question in the non-muscle invasive bladder cancer is, when do we pull the trigger and take the bladder out? Okay, that's a major escalation. And our field had research that showed, if you give more than 2 cycles of these treatments and they don't work, that's kind of the time to stop. I think it's going to be even more important with all these drugs that are floating out there, because patients are going to be clinging to one, and if one didn't work, go to the other one. And again, I don't think we have enough information to answer who's going to do poorly, who is not going to do poorly. Some of these biomarkers, like the Vesta one, has kind of a built-in prediction models. These are still pretty early, but may help us know if the patient's going to have a higher risk of progression, and when do we pull this trigger to take the bladder out. And then a de-escalation, I think it's another big question we don't have an answer to. And the de-escalation is just as important, because a lot of these drugs are just so expensive, and the financial toxicity to the patient, to the healthcare system, to Medicare, we're going to see this years later. So we do need to give these properly. We need to stop when we need to stop. We just don't know this data yet. And I think it's the same for systemic therapy too.
Absolutely. I mean, I think it's important for places like Hopkins and Fox Chase to participate in de-escalation trials, particularly because if you're a drug company and you have your drug and it's approved and you've studied it to give it over and over again, you're really you're not in the business of saying, how do I do a study to stop giving this drug, right? And not have patients get charged for this. And so it's really, the onus is on the academic medical centers to say, what is really the optimal amount of drug that needs to be given? And that's something that we've been passionate about at Fox Chase. I talked about the EV drug, and so we were running a study looking at de-escalation in patients who have great responses. We know that in the combination studies, about 30% of patients have a complete response, where all of their cancer seems to disappear on imaging, and a large proportion of them seem to maintain that response for a long time. And so in the original studies, they kept getting the drug, even though there was nothing that we could see left. And the neuropathy and other long-term side effects can set in when that happens. And so we want to better understand, how can we stop sooner, give less of this drug, and maybe preserve disease control, but also preventing those long-term complications. So I think those are really important, and we're not going to get funding from drug companies to run those studies. We need to do those ourselves.
Yeah. And so with these advancements, we have new intravesical therapies, we have new bladder preservation techniques. How can the patient discuss these multiple new options and raise them as possibilities with their provider to maybe take better into account their priorities and goals for treatment?
I mean, I think that's where BCAN comes into play. And the app that you have, I thought it was really great. I think to have the information at your fingertips when you go in to talk to your doctor. I usually tell my patients, I say it's a two-way conversation. My role is not to tell you what to do, but my role is to tell you what's available, and you're the one who's going to live with this. So you make this decision. My role is a guide. So having something that actually educates patients of what's available, the clinical trials available, is really paramount. I am a physician that treats a lot of bladder cancer, and sometimes even I get lost with all these new advances. And I think, as you've heard, about 70% of bladder cancer is being treated in the community. I think majority of the community practitioners don't even know majority of what's going on in the field. Mm-hmm. So I think the burden is on the patient, the burden is on the advocacy groups, and us disseminating this information in a way that becomes useful.
Yeah, I mean, I think I agree with everything Dr. Smith said. I think I agree BCAN is really a key resource for patients with bladder cancer that's not available in a lot of other tumors, and can really help give education and information to patients to inform them what to ask their doctors. And I think we have a similar philosophy. When I talk to my patients about their treatments, I really see it as a collaboration, and my role is to try to give as much information I can to a patient to help them make the decision that is best for them. And one patient's decision to do adjuvant treatment and get immunotherapy after the surgery may not be the same as somebody in the next room, even though they may have very similar cancers, because there are other factors in their lives or that are going on that affect that. And so we do these trials, but it's hard to always apply them specifically to individual patients. And so that's the art, I think, of what we do, and hopefully better than the art that I do in my PowerPoint, but the art of medicine that we practice.
Thank you. I'm going to ask one more question and then open it up to the room for questions from the audience. And I'm listening to your answers closely as the person who runs Beacon's research programs. What do you think is the most critical research priority in the bladder cancer field right now?
I think for me, I think it's biomarkers. Just because, again, we have so many variety of treatments now, we just need to select them properly for the proper patients. So that's number one for me.
Yeah, I totally agree. I think that's number one. I really think that's where it's headed. I think that's where there's the most potential, and I think that's going to potentially make the most difference moving forward.
Thank you. Well, thank you both very much for spending this time with us. We are going to open it up to the audience for questions. I think we'll have mics passed on both sides.
Just make sure you raise your hand so we can find you with a microphone.
Yeah, while the mic is being passed, I just wanted to kind of bring up another point. So we think about clinical trials a lot of times as therapeutic trials, but there are some non-therapeutic trials that also give us a lot of information about the disease, et cetera. And you've heard from some of the speakers yesterday and today about the organ preservation and nerve preservation. These are for during the cystectomy, both men and women. I think this is another area where some changes will be made, and I think once we get a lot more information, it'll be easier to disseminate it to outside of the large clinical centers of excellence. But there is potential for nerve sparing, organ sparing for women, and that's what I do personally a lot, and for men as well. If we leave a prostate in place, a lot of times it helps men to recover easier, keep their urinations and erectile function. We just don't, again, know 100% who's the best candidate for that. So a lot more research in outcomes, survivorship, and these types of techniques is also going on, and hopefully it will make a difference for our patients.
We have a question down here.
Hi, I was just wondering, so my tumor, well before I had any symptoms of bladder cancer, I had several months before it was vascular, and I had orange pea, and then that led me down to the road that I have a tumor in my bladder. I was positive for HCG. There is no pregnancy. My tumor was causing it. Is that being looked at as something to look at, this, non-invasive, to see if people have? I don't know if I'm like just a, one in not very many people have it, or is this being looked into? I was just...
Yeah, we see sometimes with different kind of cancers, the changes that we don't usually see in majority of the population of the patients. HCG, maybe it's very rare. I would say it's not something we will look for, but some things that can kind of point us in the direction of more advanced cancer, it's certain kind of cancers, is like elevation of the calcium, some other systematic changes. So rare but doable, but I think a lot of times when we have rare conditions like that, it's harder to answer these questions when we don't have enough patients to compare.
Yeah, I'll just add, I think there are various biomarkers that we can look at and we hope to look at. I don't know that HCG is likely to be a specific biomarker for bladder cancer. It is something that can become elevated in a variety of different tumors. We don't test for it a lot of times outside of testicular cancers generally, or some ovarian cancers, but it is something that potentially may be elevated, but it can happen for a variety of other reasons, and so probably isn't going to be good enough to be specific for bladder cancer.
Angie.
I have a question about clinical trials, and I know there's a lot out there, and I know we can find those also on the Beacon website, but is there a way to put my name with my cancer somewhere, and everybody else who would be interested in a trial? Because of course there's parameters. So you couldn't have had this medication first, or you shouldn't have had this surgery first, or so we could be out there willing to join a trial with our little blurb of us, and that way when there is one, then be contacted that way instead of having to search and then be, you missed that window of opportunity to be in that trial.
Yeah, I mean, the clinical trials are usually pretty decentralized, so it's not one place that kind of keeps check of all the trials and can reach out to the patient. There are the initiative, the clinicaltrials.org is a website that looks at kind of all the trials that get registered, I think, in the world. So you can put in the parameters such as, bladder cancer and, stage or, whatever you're interested in. It at least will pull some of the trials that are either active or inactive already, give you the institutions that are affiliated with it. And that's probably the closest that it comes to the model that you described. In the DMV area, in the DC, Maryland, and Virginia, there is an organization that's also kind of initiative of ours. It's called Gumdrop. And what we do is we just register. It's a lot of us come together and register the trials that are available in that area. And there's a website that's available to patients. So it's a little bit more kind of centralized than the clinicaltrials.org, because that's kind of worldwide. But again, it's unfortunately we don't have a really good mechanism for making it easy for the patients.
Yeah, I mean, I totally agree, and that's not the way we've done it for a long time, and so it's not set up that way. There are companies trying to tackle that, and we haven't talked a lot about artificial intelligence here, but I think that opens up the opportunity to maybe develop, whether it's around companies or ways to maybe make those connections a little bit better over time. It is hard because, as you said, these trials open and close, slots open and close, there's individual inclusions and exclusions, and it's sort of hard to know each person's individual details to make that connection. But I suspect that that's something that's doable, and AI might be a way to kind of get at that a little bit better over time.
I have a couple of related questions that relate to sort of a catch-22 or a dilemma for patients, and I think both of you touched on these. The first is when you put your slide up about the different clinical trials, some for BCG naive patients and others for BCG unresponsive. And that is a real dilemma for a lot of patients and families, because you get your diagnosis, right? And you want to start the BCG, but if you start the BCG and it doesn't work, then you're not eligible for the trials that involve BCG naive folks. You only can get into trials for the BCG unresponsive. It sort of didn't make a lot of logical sense to me, and there may be a medical reason. Maybe it's just the way trials are done. But if something is working in a clinical trial for someone who's BCG naive, why wouldn't that same thing possibly work on someone who's BCG non-responsive, even though you can't be in both groups? So that's the dilemma, in choosing your do you do BCG or do you try to do something else? And a related question is to the dilemma about biomarkers. It seems that at a lot of places that have standards of treatment, there's a protocol, and they really don't use biomarkers as part of their protocol. It's in terms of the predictive biomarkers. Would you respond to BCG, for example? We're going to go through this. Unless you're in a clinical trial, you're going to have the turbate, you're going to have this, you're going to get your BCG. If you get a biomarker test and the result predicts you're not going to respond to BCG, we're still probably going to go through our protocol and see if you respond to BCG. So you're in this dilemma: do I go get a biomarker test and not tell my doctor, or tell my doctor and have the doctor upset? And how does that fit into the doctor's protocols, where they say, well, we don't really use that? And it comes down to, this is how the dilemma is resolved. Is there any reason for a patient not to get a biomarker test, particularly one that's predictive? So if you could deal with those two dilemma situations, the BCG responsive and BCG naive, and the biomarkers, that would be of good practical help to people. Thank you.
Yeah, no, I'm sorry it gets so confusing, and you're not the only one, right? It's like everybody goes through the same confusion. So just to clarify, BCG is still the gold standard for treatment of a high-risk bladder cancer. And it's because it has the longest proven efficacy from all the drugs that we've studied. So everything else that's coming along is new. So if we have the ability, we usually would put patient either on BCG or on some kind of a trial that compares BCG with something else. Number one is these trials may not be available in majority of the places. And the other thing that makes things complicated is the BCG availability. So I think that introduces a whole another layer of complexity, because now what if you would be responding to BCG, but there is no BCG in that institution, right? So you're still going to get something else. So I think instead of, the scenario you gave of the biomarker pointing you towards away from BCG, but you still get a BCG, I think that's probably the opposite of what's going on in the community. And even the biomarker is so new, we're still, trying to get a lot more information. So this biomarker that I mentioned, the results of the trials were reported in the spring at the AUA, and they were good. But again, we're still expanding it. We're still testing it out in the larger patient population. So I think all this information is great and it's helpful, but it's so new that I don't think you want to bypass the standard of care and go on to something else. Obviously, if there is some treatment that proves to be drastically superior to BCG, eventually will get adopted. We have the trial, the gemdosi trial, the bridge trial at Hopkins and some other institutions as well, that looks at the comparative effectiveness of BCG naive patients getting BCG versus gemdosi. So once that data matures, I think we'll have better kind of idea of what to recommend. And as I mentioned, a lot of these BCG non-responsive trials have now moved to the phase of the BCG naive trial. So it's the same drug that's being tested in the other population as well. So I hope this makes it clear.
Yeah, I just want to answer your question with not specific to non-muscle invasive bladder cancer, but with my clinical trial design hat on. So to your question about BCG naive versus not, and so I think the first point is when you're designing a trial, you want to study a drug and see if it's effective in a certain population, and you sort of have to make a decision about how broad you want to make that population. That may allow more patients to be eligible for you to complete the trial faster, for you to get more people on. But if that pool of patients has a lot of different risk factors, a lot of different stages of disease, it may be hard in the end to really know how effective the drug was. And so when you're designing a trial, you sometimes have to sort of design these trials in specific pools of patients, BCG naive, BCG unresponsive, BCG refractory, so that at the end you have a homogeneous group that you can actually say it works or doesn't work. And so I understand the frustration, but there really is sort of thought behind it. And so that's where sort of that part comes in. And then the other thing I'd sort of say to all of you is before you start a new treatment, ask your doctor about clinical trials. I think that's the time, because if you start new drug X with your doctor and then go seek your second opinion, you're right, you've burned a bridge, and you're not going to be eligible for a trial in this setting if you've already started your drug. And so I know it's hard to do that when you're first diagnosed and you're just trying to understand this disease and so much about it, and to not knowing anything about trials, you may not ask that question. But for those of you who are here that are trying to educate yourselves, anytime you're thinking about starting a new therapy, whether it's non-muscle invasive, muscle invasive, metastatic disease, that's the time to ask, is there a trial? Is there someone else I should go? Because you don't want to miss those opportunities.
And is there any reason not to get a...
Oh, yeah. Yes. So there, I do think if there's a biomarker that is not... does not clearly help make decisions about treatment, just because it's marketed or is out there as a potential biomarker to predict something, that does not mean it's the right test to get. And I'll give a good example, actually. So I mentioned the ctDNA testing for patients after their bladders have been removed, which has been shown if positive, those patients are probably higher risk of their cancer recurring and may help make a decision if you want to do an adjuvant treatment, so treatment after surgery versus not. But we don't know yet for sure that making that test, if it's positive, you have to get treatment. If it's negative, you definitely don't need it. We don't know that yet. It hasn't been studied that way. But it's out there. You can order it. I can order it. A patient can ask for it. So I tell my patients when we're having this discussion, this test is available. If you think a positive test or negative test would influence your decision, we can order it. But if you want treatment no matter what, or we think your risk is high enough that you want it, I don't think the test is helpful. And if you absolutely don't want treatment because of whatever reasons, I don't think the test is helpful. And so I think you have to know what you're going to do with the information from the test before you order it. And there's things out there that don't necessarily provide that.
Great questions, Hart. Thank you. Yep.
Thank you for your talk. It's wonderful. My question to you is, after bladder cancer, I was diagnosed with Lynch syndrome with total loss of MSH2, partial MSH6. My question to you is, do you support, after somebody's had 2 cancers, do you support genetic testing to find out if there is a genetic problem going on and I just had my 4th cancer, by the way. So what is your feeling about genetic testing for a patient who's had multiple cancers and doesn't know that they may be harboring a genetic mutation? And what about the families as well? Should they be tested?
So, sure, I can answer. So absolutely, if someone has a cancer and it's sent for mutation testing in the cancer, but you find that you're what we call MSI high or microsatellite unstable, that could be a sign that you have an underlying Lynch syndrome, so a genetic syndrome that led to that, and those patients should get treated. But really, any patient that has that's younger than you would normally expect, has multiple cancers, those patients should get genetic testing, and anyone who then, if the patient is tested and has a mutation, absolutely families should be counseled and tested. And it's important for screening and planning for other family members and patients, but it also opens up treatment opportunities potentially. Lynch syndrome tumors tend to be very responsive to immunotherapy, and so something that is important to know. And I'll say in the bladder cancer community, patients with upper tract tumors, so tumors of the upper tract, are a little bit more likely to have Lynch syndrome. And so if you have an upper tract tumor, that is something you want to ask your doctor about, and potentially testing for that might be relevant.
Yeah, I don't think we have really good guidelines on the genomic testing for the bladder cancer because it's mostly cancer exposures.
Right.
But definitely, yes, if there are multiple relatives or multiple cancers, especially if it's upper tract tumors and tumors that go hand in hand with Lynch, like the colorectal, et cetera, and the uterine and things like that, definitely it doesn't hurt to get tested.
Yes, I had a question. If there were no BCG shortage or an individual had access to alternative sources of BCG, what period would you recommend continuing the BCG for?
Yeah, so this goes in, the thinking behind this is the risk classification for the non-muscle invasive bladder cancer and some of the data that we have that tells us about how long to give the BCG. So the SWOG trial from multiple years ago put patients, especially high-risk patients, on a 3-year of maintenance. I think that's kind of the most optimal BCG maintenance protocol we've given to the patients. Now with a shortage of BCG, our society recommends shortening it down to a year. The interesting thing is if you look at these papers and the research, majority of the people actually never made it to 3-year BCG maintenance because of the side effects they developed. So the data is not as clear-cut as it may sound. And then, sometimes, we really don't have a data to continue the BCG maintenance past 3 years. And, I don't know how that's going to progress with this BCG situation eventually.
So you would stop at 1 year, or if you could get 2 or 3, would you keep
Yeah,
going?
I mean, when the BCG was in ample supply, I would give BCG maintenance for 3 years if the patients would tolerate it. But I feel like BCG has been short like forever. I don't remember the last time we had a good BCG supply without any issues.
And one last follow-up. If you were into, say, 2/3 of the year of maintenance with BCG, would you continue that without looking at other alternatives until you see if that gold standard worked?
I'm sorry, I didn't get that.
If you're, say, into your 6 months of maintenance treatments, would you look at any other alternatives or see if the BCG is going to work?
So some things that we've come up with to mitigate the BCG shortage, there are some protocols that look at the reduced frequency of BCG maintenance and reduced dosing of BCG. When we look at the data, it looks like if the BCG is given at reduced frequency, there are more chances of recurrence, but not progression. So it still treats the NMIBC well, but you might have non-muscle invasive tumors grow again if it's not given at the optimal schedule. But it's something that's treatable. The question of switching from BCG maintenance in the middle of the maintenance to like chemotherapy or something like that, we have absolutely no data to talk about this. I think these are anecdotal kind of things, and a lot of the times what my personal approach has been to the patients is if you're cancer-free at the moment, it's hard to justify to start a brand new treatment, and we just won't know if that's going to work or not. So I usually would just tell them, if the cancer comes back, we'll treat it.
Thank you.
Karen?
So my question is about pathology. How often does the pathology, change over the course of the disease? And what are the implications for treatment?
And we're talking about the non-muscle invasive or?
Either one. I mean, I had a patient who had, at TURBT was urothelial carcinoma, and then after cystectomy, he had a non-muscle invasive. He had muscle invasive, and then after cystectomy, pathology was then sarcomatoid.
Yeah,
Yeah, I would say not that often that it changes. Now, part of that is also sampling, right? You may get a TURBT and only have so much of the tumor, and then you have a surgery and you have the entire tumor. We will, in the world of metastatic disease, if patients' cancers are, a new area pops up where other areas are responding and they have sort of a mixed response or something is growing differently than it had been before, we might rebiopsy, and one of the things we might be interested in is has there been some change, whether it's new mutations or some histologic change. Although to be honest with you, it doesn't necessarily translate to different treatments many of the times. We don't necessarily have different drugs that we give for sarcomatoid or micropapillary or some of the other rare variants. And so it may give us some prognostic information, but it may or may not actually translate to changing in therapies.
Yeah, and some of the things that are very interesting about this question is, so what you've described, the sarcomatoid, it's sometimes called a variant histology cancer. So variant histology cancers, interestingly enough, are not that easy to diagnose and spot. So if you look at the non-GU pathologist reading the slides, if you take the same slide and give it to a pathologist that's a GU pathologist, they might give you a different conclusion. It happens about 30-40% of the time. So whether it was not there or it was there, it was just not spotted. That's one question. The other thing is, these invasive, these variant histologists sometimes are more aggressive. So is it possible that we treat the tumor, we give a neoadjuvant, or we scrape it off, and some of the more invasive variants are still embedded and they keep growing? That's kind of a great question. I don't know the answer to that. And then the biggest thing is the tumor heterogeneity. So if you have a lot of tumors, some areas have certain cells, the other areas have certain mutations, and you need to have as much of the tumor as possible to make this diagnosis.
If a person is BCG non-responsive, are there certain drugs that are apt to work and certain drugs that are not apt to work? And I'm interested in knowing which ones are apt to work if that's the case.
Yeah, you're asking the $1 million question. Again, it goes to the biomarkers, right? Because we have now 2 FDA-approved drugs, the Adstiladrin and the Anktiva, that are approved for BCG non-responsive disease with CIS component. And we don't know which patients will respond better to one versus the other. So we just give what's available.
Gemdoc, is that something that?
Yeah, so Gemdosi is being, Gemdosi has a fairly good response to, again, no data to predict who's going to respond to Gemdosi versus a second course of BCG or versus Anktiva and things of that nature. Again, goes to biomarkers, and hopefully we'll have more information. Gemdosi trial in the BCG non-responsive space showed some decent results. I think most of the drugs in the space, when you look at the long-term efficacy, it ranges between 30 to 50% for the BCG non-responsive tumors.
Any other questions? Now is your opportunity. Raise your hand and we'll get the microphone.
not seeing any? Okay. Well, oh, we have one.
I was wondering, is there a website that we can go to see what's happening besides Beacon? Is there one that you would recommend for us folk here that we can go on and see, oh, this is happening here. Maybe this is something we either want to track, someone we want to call or email, or
To get information about just bladder cancer in
Trials.
general, or about trials,
No,
or about
trials.
about
I'm
trials?
sorry, about trials. I know that I've gone, I've seen them. It's been very helpful. I can tell which particular hospitals and facilities are participating. I might even recognize a name. It'll tell me about where they are in the trial. Is it, stage 1, stage 2, whatever. So that's
So
what
I
I'm
don't know that
asking
there's
about.
a perfect resource out there. Beacon may be the best place to start. If you go to organizations like ASCO, the American Society of Clinical Oncology, or the NCCN, those may also have resources. There is clinicaltrials.gov, which is the website that all clinical trials have to register in order to, through the FDA. It's not really intended, though, it's not patient-friendly, I would say. So you can get a lot of that information in there, but it's not really designed as an interface for patients to use. But it is another resource out there that that's free and searchable and that you could look at.
What was that again?
Clinicaltrials.gov.
Can I just say on that point that you're right, it's not friendly. It's not user-friendly.
I mean, it's
but-
not designed for patients in
But
mind.
if you go to clinicaltrials.gov and you can put in all kinds of keywords like NIMBC, you can put, Cornell University or Mayo Clinic. You can put whatever words you want. And I mean, I did one for on NMIBC, and I got something like 50 trials around the U.S. And then you have to look at each one, and you have to see where the locations are. Some trials are being done at 15 locations. Mm-hmm. Some trials are being done at only 2 locations. Some trials are solely diagnostic, have nothing to do with treatment. Looking at should you get a urine biomarker test instead of going for a cystoscopy. So there's maybe too much there, but if you really plug through it, you'll get the answer to what you want.
I just want to add too, with Beacon's website, we take all the open trials that are there for bladder cancer here in the U.S., because we're a U.S.-based organization. And what I think is really helpful is many of the trials come under the leadership of phenomenal people like Dr. Zibelman or Dr. Smith, and they're the PIs, the principal investigators on the trial. But they know that in order to get the number of people they need to prove or disprove their scientific hypotheses, their question they're trying to ask, they're going to need to go outside of Fox Chase or even Johns Hopkins to get enough patients. So they often deputize some of their community-based colleagues who do the research in the community, the large practices that might also want to feed into a clinical trial. So they're sort of sub-PIs. They're working with the major investigator to get those trials done that might be more convenient to you in your community if you don't live near a large academic center where some of these trials are sponsored. And I think that our pharma partners do a pretty good job also of engaging larger medical practices to spread those trials out, to really get a more representative sample across the board of people in different parts of the country. Maybe they're rural or urban, depending on what their resources are. And you all are engaged in some of these larger trials as well. So as you go through, even on our dashboard, and you get to the bottom, you see all those sites. Find one that would be convenient to you and call the clinical trial coordinator and find out if you were eligible.
Yeah, I would also add to that, In addition to the clinical trials portion of Beacon's website, we also have a treatment matrix. So once a study is closed and then it goes through approvals and the drug is available, we then try to get it on the treatment matrix as quickly as possible. So you can check there to hopefully see a pretty current list of what is available and in use.
Any additional questions for our panel? Okay,
Okay.
close it down.
Well, thank you very much. I want to thank our experts for spending the time with us today and sharing your cutting edge knowledge of what's going on in the field right now. So thank you again to Dr. Smith and Dr. Zibelman.
Thank you.